Um, so welcome. The article we're looking into today is a fascinating one in my mind. It's by a researcher whose name is Justin Feinstein, who's probably the leader in the field of chemoreceptors, right? The parts of the brain and body that sensing carbon dioxide and changes in carbon dioxide, and how that relates, particularly in his lab, to fear and anxiety. So he's got this very unique opportunity, or had the very unique opportunity of studying people that have lesions on their amygdala. And we know the amygdala is very much related to fear. And so what his big kind of breakthrough or groundbreaking moment was, they actually had a patient in, or a subject in, that had bilateral amygdala lesions. So technically can't feel fear, can't experience fear. And they made her breathe in carbon dioxide and she had a panic attack. It's the first time she's ever felt fear in her life, right? It was a genetic defect, don't have amygdala. And then she breathed in a straight CO2, or a higher concentration of CO2, and had this immediate overwhelming sense of panic. And her words is, I'm going to suffocate, I'm going to die. And so that kind of opened up this world, right, as to the relationship between carbon dioxide and how the brain responds to that change. Someone that doesn't technically feel fear still had this overwhelming fear response when CO2 is increased. And it's really interesting. This person had been studied, because it's quite a unique, change to have in the brain. So they'd put this person in lots of fearful situations, and she never has a fear response. So they kind of tied that to, okay, can't experience fear, but now we have this more chemical inducing or physiological inducing fear response. And so what this kind of study looked at, it was a combination of looking at this subject amongst other kind of brain-based looks at what happens in the brain when we change levels of carbon dioxide. So the name of the paper is Amygdala-Driven Apnea and the Chemoreceptive Origin of Anxiety. It's a bit of a mouthful. If we kind of take away the sciencey words, right? When fear drives breath holding, and how the chemical sensing system of the body produces anxiety. And so the kind of traditional belief as they approach this study, right, and what we see the amygdala as is the fear center. It's responsible for making us scared. But what this study kind of pulled out was that the amygdala might not just give us fear, it might also interfere with our breathing. And it can actually make us stop breathing without us actually being aware of it. So this apnea-induced anxiety is triggered by the amygdala. We're going to break this down in a lot more, detail and nuance, but just to kind of give us a little bit of an overview. And so this idea of apnea-induced anxiety, or breath-holding-induced anxiety, the amygdala, by kind of stopping us breathing, creates this chemoreceptive change, right? There's an increase in the amount of carbon dioxide in my body and my brain, and that can induce this feeling of panic and fear. This relates to something I often talk about called the false suffocation alarm. We've got a network in our brain that responds when CO2 goes up. And if I pause this kind of research paper for a moment and just give us some background on that, our brain is incredibly sensitive, not to falling oxygen, but to rising carbon dioxide. The reason being, when oxygen levels go down in the brain, we have a pretty kind of fail-safe mechanism of turn it off and turn it back on, right? The brain consumes the most oxygen in the entire body, something like 2% of our body weight, but 20% of our metabolic demand is the brain. So if oxygen is going down, the brain's fail-safe mechanism is turn it off and then reboot the system and see what's going on. And so if we think evolutionarily, if every time oxygen started to drop, we hit the deck, right? We pass out. And so we've developed a kind of, pre-passing out mechanism that as carbon dioxide rises, we get this very strong response from the brain. Because when CO2 rises, it signals that the next likely thing to happen is oxygen is going to fall. So it's this kind of predictive mechanism that the brain has, that if CO2 is going up, oxygen might be about to fall. So that's a big problem. And we have this big response from the brain that kind of says, CO2 going up, oxygen going down, we need to act. Okay, here is this kind of anxious response. And so for people with kind of chronic anxiety, it's as if their body is kind of struggling to stay balanced between these moments of too much carbon dioxide, not enough carbon dioxide, breath holding, over breathing. And what I tend to see a lot clinically is this kind of hypocapnic or hypoventilation. I'm holding my breath and then I overcompensate by breathing too much. And because I breathe too much, I hold my breath again. And then I respond to that and I overcompensate. And so we go through this kind of overbreathing, underbreathing, overbreathing, underbreathing. And if we think through this lens of physiology, how disruptive that could be for the brain. Carbon dioxide very much kind of controls the pH of the blood. So lots of CO2, little CO2, lots of CO2, my pH is going up and down and up and down. And our pH is very tight knit, right? We move either to alkaline or to acidic, and many functions in the body just can't function, right? So we have to stay in that kind of pretty tight window. And so we start to see this picture of, okay, with someone's not aware of the fact that they're holding their breath, and then they overbreathe, we're continually just swinging their pH up and down and up and down. And so what this study looked at is kind of shining a light on this chemoreceptive system, right? Which is kind of a fancy term of how our body senses changes in chemistry, particularly related to breathing and even more particularly related to carbon dioxide. Because when carbon dioxide kind of dissolves in the blood, it forms carbonic acid, so it's acidic, and that's how it actually impacts pH. So the kind of bottom line here is anxiety is not in our heads. It's not a mental thing. It could well be related to our breath and our body. And the understanding of that can really kind of change how we tackle anxiety. And so if we kind of like dive a little bit deeper in here, there's this kind of intricate dance between breath and anxiety. This study kind of unravels this connection between the amygdala, the kind of fear center of the brain, and this onset of breath holding. And so what the study actually did was stimulated people's amygdala. And so they did that through transcranial stimulation. So they actually, inside someone's brain, stimulate the amygdala. And what they saw was breathing stopped. They stop stimulating the amygdala, breathing resumes. Stimulate the amygdala, breathing stops. What's really fascinating is the person whose breathing stopped was not aware that their breathing stopped. There was no air hunger. There was no feeling of suffocation. While the breathing had stopped, there was no awareness, because what the amygdala does is it inhibits our chemoreceptors. So what stimulates the amygdala, if not a scientist with an electrode, is typically fear, right? So this is putting together this model. And when I say fear, right, it could be fear from an external, right? Something scares me. But how often is our fear coming from an internal, a thought, a memory, a projection of the future, right? Those things can make me feel scared. And this paper is proposing that those little bouts of fear actually stop someone breathing. They don't know they've stopped breathing. Because they've stopped breathing, carbon dioxide is beginning to build up. They start breathing again because maybe the fearful stimulus has passed and their brain is overwhelmed by high CO2 and it thinks it's going to suffocate, this false suffocation alarm. So they get this panic-induced kind of response where they overbreathe, they push the CO2 out, and then we start this cycle, right? And so this kind of chronic up and down is perhaps coming from the fact that the amygdala inhibits breathing. We're not aware of the fact that carbon dioxide is rising and chemistry is changing. Once breathing resumes, the amygdala stops inhibiting chemosensation, the brain freaks out, right? And it overreacts. And we just go through that cycle. And so at this kind of the heart of this chemoreceptive system is pH, right? The chemoreceptive system is kind of responsible for regulating blood pH. When pH changes, there is a almost immediate response in our breathing. Breathing either speeds up or slows down to kind of get us back into that ideal range. We're not going to talk about it too much today, but if it is an area of interest, we can dive into it, perhaps at another point. But chronic dysregulated breathing, so chronic hyperventilation, we actually start to see a compensation from the kidneys, right? So the kidneys, their role of either excreting or retaining bicarbonate, which is kind of what balances out the bicarbonic acid. If I'm over breathing all the time and get rid of that CO2, my kidneys have to kind of compensate to sustain pH. But when we're looking at the chemoreceptive system, we're talking about kind of immediate changes. So hold my breath, breathe faster. That kind of like pH goes up, right? I'm becoming a little bit more alkaline, breathing slows down, or even holding the breath. So it's kind of the conductor of the orchestra. Even slight shifts create these kind of pretty quick compensatory changes. And so we have what are known as peripheral and central chemoreceptors, right? Peripheral in the body, central in the brain. The peripheral chemoreceptors are mainly in the carotid arteries, which are the arteries that go from my heart to my brain. We also have a kind of high density in the aorta, the big kind of tube that comes out of the heart. And the central chemoreceptors are in the amygdala, right? And projections from the amygdala. So it sets up this really kind of like delicate situation that when someone has perhaps an oversensitivity or a kind of overreaction to these changes in chemistry, because of the role of the amygdala, it directly impacts breathing. But when our breathing is impacted, it directly impacts our chemoreception. So it's this really kind of like bidirectional chicken or the egg scenario that the brain is impacting these more peripheral mechanisms, the peripheral mechanisms are impacting the brain, and both of those things are kind of swinging someone out of balance. So what's kind of come out of this is this model, right, of the kind of amygdala-induced anxiety, that the recurrent kind of unconscious breath holding that occurs is what's generating spikes in carbon dioxide, which triggers anxiety. And that kind of chronic persistent anxiety disorders may well stem from a chemoreception problem rather than anything else, you know. And I think anxiety is a very interesting topic because I know what anxiety feels like to me. You know what anxiety feels like to you. We may be describing two very different things. Anxiety is somewhat subjective in nature, right? I don't know what your anxiety feels like, and you don't know what my anxiety feels like. And so some people feel anxiety is very physical. My heart's pounding out of my chest. There's a weight. My throat feels like it's closing. I'm tense. I'm flushed. Others, it is very mental, right? My mind is racing. I can't think. I can't concentrate. And others, it's an emotion that they're experiencing, right? It might be tinged with fear. It might be tinged with apprehension. And so when we say anxiety is this, it kind of loses that nuance of, well, my experience may be more physical, yours may be more mental, and someone else's may be more emotional, tending to be it's a blend of all three. And so what this kind of model proposes is rather than it being, you know, a psychological or mental or an emotional, like, let's look at the physiological origin of why someone is experiencing anxiety. The work that I do with clients, I've found this to be a very accurate model, for lack of a better description, because when we work to restore optimal chemosensation, right? And an easier way to describe that is when we restore a better relationship with carbon dioxide, right? I can improve my tolerance, reduce my sensitivity. My clients tend to find I'm less anxious, right? Because they're not reacting to these internal disruptions as much. And so what does that mean for kind of practitioners? I think it really kind of puts breathing-based exercises at the forefront of our strategy to help someone manage anxiety. You know, it kind of reshapes the approach. Typically, our main approaches to anxiety today in the kind of Western medical system, number one is pharmaceuticals, right? We give someone anti-anxiety medication. Number two, cognitive behavioral therapy. We talk about it, right? So we're addressing it from a psychological standpoint. Number three, you know, is kind of like the more alternative strategies. It may be nutrition, it may be exercise, it may be sleep, it may be social engagement, right? It might be strategies of kind of like fear, where we're looking at kind of exposure therapy. But instead of kind of first line defense being medication and second line being talking about it, perhaps we can kind of propose this like, well, what if we address breathing first? What if we at first, right, target the thing that creates fear and anxiety in the body, the amygdala? And we do that through kind of understanding that the amygdala responds to changes in pH. So just to kind of, and I maybe should have done this a little bit earlier, but, you know, coming up with some simple definitions of chemoreceptive system, right? Chemoreceptive, so responding or receptive to chemistry. So it's kind of like an alarm system, and it's very much related to changes in oxygen and carbon dioxide and helps regulate our breathing and also plays a role in how we feel, right? So we're sensing the internal chemistry of the body. Apnea-induced anxiety, right? The name of this kind of model is kind of, again, when anxiety is causing us to hold our breath without us realizing. That stopping of our breathing causes a change in our physiology, which can trigger feelings of panic and anxiety due to this kind of missed alarm system. And then the final thing that I think is interesting and where we're going to come to in terms of what can we do about it is interoception. Most of us have heard of introspection, right? I'm introspecting, I'm thinking. Interoception is our ability to sense our internal state, right? Exteroception is me sensing the outside world, and I do that through my five senses, what I can hear, taste, touch, feel, smell. Interoception is sensing my internal environment. Can I feel my heartbeat? Do I feel hot? Do I feel cold? Do I feel hungry? Do I feel tired? Am I tense? Am I relaxed? This is all interoception. Really interestingly, when we tend to look, and I'm kind of generalizing here a little bit, but people with heightened states of anxiety and panic tend to have really poor interoception. They don't notice their breathing change. They don't notice their heart rate change. They don't notice their temperature change until it's kind of like the proverbial too late. So it's been changing for a while, and then it crosses this threshold, and then it feels very overwhelming. And so with those kind of three things in mind, the main, I guess, takeaways that I want to introduce from this study. Number one is let's look beyond the mind, right? When we're looking at kind of origins of anxiety. Now we can kind of relate anxiety more to a physiological process and a brain-based rather than a mind-based issue. And that helps target, well, what are the strategies that are going to address physiology rather than psychology or emotions? The second is breath awareness. And those of you that have spent, even a little bit of time listening to me talk, over even months or years, breath awareness, I think awareness is it is step number one. Because again, if I don't notice that I'm holding my breath, if I don't notice that I'm breathing rapidly, if I don't notice that I'm breathing up into my chest, there's not much I can do about it, and if I fail to recognize those underlying changes, I tend to blame my symptoms or my response on something external. The example I always like to give for this, someone says to me, I have social anxiety, right? Being in a group of people makes me anxious. Even the language we use is very interesting there. That's not necessarily true, right? Someone that has social anxiety, being in a crowded room makes them change their internal state. Their breathing changes, their posture changes, their internal narrative changes. It's those changes that give them the experience of anxiety, right? Anxiety isn't happening to them from an external source. The external source may trigger these internal disruptions, but it is those internal disruptions that are actually creating the anxious state. So being aware of, am I creating the internal disruptions because I'm holding my breath, because I'm breathing rapidly, because I'm tensing my jaw? The more aware of that I can become, the more I'm able to use the right intervention to perhaps prevent that. It also kind of proposes this idea of kind of, early intervention, right? If I can get someone to do a breathing exercise before they cross that threshold and they feel like they're on the verge of a panic attack, it's kind of like filing down the edges, instead of there being these huge peaks and troughs, as I feel myself going up, I course correct and I can stay in that kind of homeostasis or balance point. What we tend to find with people that experience a lot of anxiety, I shoot up and I have an anxiety attack or a bout of anxiety, and then I crash back down. And then something draws me up and I crash, and up and down and up and down. Because I feel that we're not implementing interventions or strategies early enough, right? We're waiting till I'm anxious right now rather than I'm becoming anxious. And that's a big difference in how we can kind of respond to that. The other component, or the other two components, is kind of integrating this understanding of breathing with other therapies, right? So the therapist who's using cognitive behavioral therapy that can also use breathing as an intervention, right? The doctor that's perhaps looking at prescribing certain things can maybe also supplement that or add this in terms of self-regulation. And the final thing that I'm a huge proponent of is education, right? If someone understands the origin of their anxiety is not outside of them, is not happening to them, it can be incredibly empowering, right? And it's not to say, hey, you're creating your own anxiety, it's your fault. It's to say it's within your control, and if you can catch these things that are happening with your breathing, perhaps you can take more control, right? So this understanding of this connection between my breathing, my amygdala, and my anxiety can kind of empower individuals to take a more active role in managing their anxiety through breath awareness and kind of intentional breathing practices. And so if we kind of change gears one last time, and then we'll kind of open it up to some questions, strategies that we can take away. So the first one is breath awareness. Breath awareness sounds inherently simple, become aware of my breath. In practice, if any of you have sat and tried to do that, it's a lot more complex than just sitting and noticing my breathing. Breathing is intentionally relegated to the back of my awareness for a reason. We breathe 20, 25,000 times a day. Imagine if you noticed every single one of those breaths. You wouldn't get anything else done. You wouldn't notice all of the other important things. So this happens a lot in terms of when the body has a constant stimulus, it tends to kind of drown out that. Like the example I often like to give people, right now, most of you can't feel clothing touching your skin until I just said that, right? And then you notice, oh, wait, now I can feel my t-shirt or my pants, right? You were sensing it all the time. It just wasn't really relevant information. But the moment I said that, your intentional awareness is like, oh, wait, no, I can feel that sensation there. But it's not relevant 24 hours a day. So we relegate it. Same thing happens with breathing. Because it's happening all the time, the brain's pretty good at just ignoring it, unless there's a very dramatic change. But like any practice, if I sit and become aware of my breath intentionally, for periods of the day consistently, that part of my brain that's aware of my breathing becomes a little more alert, becomes a little bit more online. And I start to notice these more subtle changes. So instead of waiting until I'm hyperventilating, I notice, 10 minutes before that, my breathing got a little bit faster or got a little bit more erratic, or it moved a bit higher up into my chest. Those little signals and reminders can be enough for, I need to course correct. I need to slow down my breathing. I need to drop it back down to a diaphragmatic breath. I need to, whatever the appropriate response is based on each individual. Which brings up my next point of having individualized breathing plans or programs or targets. Because some people breathe quickly when they're anxious and other people hold their breath when they're anxious. So the same intervention is not always going to work for everyone. Anxiety, particularly, but even breathing is not a one size fits all, right? It really depends on what are your kind of cues, what are your responses, what do you notice? And now I can kind of introduce what the right intervention is. And speaking of, simple interventions, arguably the simplest is kind of breath pacing, right? If I'm in control of my respiratory rate and my respiratory pattern, then that stops me holding my breath or breathing rapidly, right? So if someone tends to be a over breather, well, then slowing down to a more natural pace can kind of like restore that balance of carbon dioxide and potentially prevent anxiety. The final kind of strategy is more what I like to call rescue breathing, right? And it's kind of training individuals, for specific scenarios of when you are very anxious or when you are having a panic attack or when you are experiencing these emotions. Can I have this kind of like almost knee-jerk reaction is let's come back to this rescue breath pattern, which is targeted to change my physiology, right? So get rid of the physiological driver of my fear and anxiety. It may not change anything in the external environment, right? Maybe my boss is still yelling at me, or I'm having an argument with my partner, or my kids are being difficult, But often there's these kind of like, the external and the internal combined to create anxiousness or fear or panic. And if I can control one of those things, right, I might not be able to control my boss, but I can control what's going on physiologically through these kind of rescue strategies of like, let me just get my internal state back into balance, and then I can deal more effectively with the external stuff. So I'm going to pause because I can just sit and ramble about this all day. And just give, if there is an opportunity, Annalene, I know you had your hand up earlier. I only just kind of noticed that, and then it went back down. Any specific questions? Anyone can just kind of pop themselves off mute and jump in with anything that they like.
I can't quite remember what it was. Sorry. That it was at the moment. I think you said it in quite a definitive way, kind of like it is like this with the amygdala. But I think afterwards you broadened it out again. So that's why my hand went down.
Okay.
Yeah. But yeah, I subscribe to every single thing you say, and especially I always say once you're aware, you're halfway there, because then you've got the choice point, right? But that's the difficult thing. And of course, the less aware people are, the more they blame anything on external circumstances and look for solutions in external environment, as well as into pills and potions and lotions and whatever. And I think that's our biggest problem.
Yeah, I couldn't agree more.
Yeah.
And it's such a, again, it's this paradox where it sounds so simple of develop more awareness. And if it were oh so simple, but I think, for me, I love this idea of breath awareness is self-awareness. When you're aware of your breathing, you are also aware of your posture, and the story that you may be telling and the situation that you're in. Whereas when we're not aware of our breathing, we could be up in our head, projecting into the future or remembering the past, and we don't notice that we're tense and that we've clenched our jaw and that our breathing's all erratic, and we go, I feel so terrible because I've lost that sense of, in the moment awareness. So I love to see breath as like, that's that kind of thread that we can pull on to stay grounded in a little bit more of a present state. Glad you kind of find the same thing. Thanks, Annalene. Anyone else have any questions or insights they'd like to share? Claudia?
I just wondered about breathing in relation to kind of the immediate trigger of vasovagal syncope. If it can be useful, because I have a grandson that has that in response to being hit in his abdomen when he was about 2.5. He fell on a blunt object and passed out. And since he's had a few other instances of it's usually with getting hurt. And it's so hard to find really good information. It's just like, oh, that happens and you move on. It's like you can't do anything about it. And I wondered about breathing for that.
So do you, and this might be a guess on your part, or maybe you are more aware of it. Do you think, because you mentioned it tends to happen when he's hurt or in pain. Typically, if we think of our kind of pain response, we tend to hold our breath, right?
Right.
And that gasp reflex and then holding, what I always find fascinating when we're talking about, vasovagals or dizziness or passing out or loss of consciousness, if we think of pressure systems is the way that I like to explain it, right? So we've got kind of intra-abdominal pressure. So if we think below the diaphragm, we have a certain amount of pressure in the abdominal cavity. We have intrathoracic pressure, so between the diaphragm and the throat. And then we have intracranial pressure, right? The pressure that's within the skull. Those three systems are linked, right? If I take a big breath up into my chest, right, I've increased the pressure there, I'm going to have a resulting compensation from the other two systems. What I tend to find, and again, it's can be quite unique in depending on the individual, but if someone's got that kind of gasp response and they get dizzy or they are on the verge of passing out, it can be a kind of backing up of pressure, right? So they've increased the pressure in their thoracic cavity. Blood flow that's trying to leave the head is now coming up against that backlog of pressure, right? The only way that blood leaves our brain is the pressure in my chest is less than the pressure in my head, right? And so it's just the kind of pressure dynamics. So if someone and then holds their breath, for example, and maybe there's some tension there, it may well be this kind of spike in intracranial pressure because the blood's getting backed up, right? And perhaps there's a sensitivity there in this kind of the vasovagal response for your grandson that maybe it is, fear or pain, and I hold my breath and create that pressure, and there's that kind of predisposition to maybe having a vasovagal. That would be my, and I want to preface that it's more of a hypothesis without, being able to do more of an assessment. But I tend to find the kind of dizziness response that people can get, it's usually like I overinflate and then there's a backlog of pressure.
Okay, that makes sense.
So, it might be worth, if you ever are, or you can ask, his parents, like when he has those episodes, like, can you notice what he's doing with his breathing? Is he holding his breath? Right. And based on this kind of study, like something I'm fascinated by at the moment is called anticipatory ventilation, right? I'm anticipating something scary or exciting or whatever it might be, and there's an impact on my breathing now in the present moment, right? The great example of this is people that get very nervous of going to the doctor. Tomorrow I have my doctor's appointment, right? You're changing your breathing now based on the fact that you're apprehensive about the thing that's happening tomorrow. And it's kind of like, a self-fulfilling prophecy because now I've dysregulated myself for 24 hours and then I get to the doctor's surgery and I have an anxiety attack. How much of that was because you've been pushing yourself out of balance for the past 12 hours or 24 hours? So perhaps there's a bit of a learned response, if it's something fearful or something that, could be scary or maybe is related to pain. And we have this anticipatory change in breathing, which is maybe bracing and overinflating. That would be kind of where my mind goes.
That makes sense because there's been a couple times he hasn't passed out because he kind of knows to drop, to sit, and he'll just drop. And sometimes just that helps him to not totally go unconscious kind of thing. So maybe that drop causes that pressure thing to just change just by positional
Yeah. And the experiment that I would maybe run if it was my grandson, or if it was, someone I was working with, is, it sounds like he has enough awareness around these episodes now to sit down.
Yes,
You also, when you have that kind of, feeling,
breathe out.
drop the exhale out.
Uh-huh. Okay.
Because again, very much related to pain and anxiety, we're usually at the top of our breath, right? And if I sustain that, that's when I kind of continue to swing the pressure gauge, So if my immediate response is just kind of like drop the pressure, maybe we see what happens.
That's great. Oh, yeah. I'll try that with him. I'm with him a lot, so I could experiment that.
Yeah, keep me updated. That's very interesting.
Yeah. Thank you.
And Megan or Sarah, do you either have questions or anything you'd like to add? Oh, Megan, I see you driving, so.
Oh. Can you hear me?
Yes.
Okay, I am driving. I don't have any questions. I thought this was fascinating. I absolutely loved it. So I just want to say thank you. And also thank you for asking how I'm doing. I was washing my hands. I'm good.
Glad to hear it.
All right, thanks.
Thanks, Megan.
Hi, I don't have any questions either. I just wanted to pop on and say thank you. Super interesting. Really appreciate your content and all of the knowledge that you're sharing with us.
Oh, thanks, Sarah. Appreciate it.
Thank you.
So what I'll do is I'll upload this recording. There'll be a little section within the classroom of just kind of like recordings, and I'll add quite a bit of text to it. So even if you don't, necessarily need to watch the recording, it might be a good idea to come in and like, here are the takeaways. Here's what I could perhaps apply with clients or in my own life. So there'll be a bit of a, shorter, concise summary that you can all kind of grab as well. But thanks everyone for joining and sharing this with me. So we'll do these every month. Again, I didn't mention you around here at the start, Sarah, but if there are any areas that you're interested in, send them to me, and be like, hey, is there any research on this, or how does it relate to this? And I can do some digging, because I like to do this stuff. But I hope everyone has a lovely rest of their day and weekend ahead. And I'll see you.
Thank you very much. And have a good move.
Thank you.
All right. Take care.
Thank you. Bye, everyone.
Bye-bye.